Good evening, everybody. Good evening, Kat.
Evening, how are you?
Good, good. We have glorious sunshine.
Oh.
Everybody's out barbecuing and walking, and so it's lovely. Bit
Yeah, it's not quite the
not got
same
that
in
there.
London, a little bit overcast. It was a bit of a disappointing day,
Oh,
but it's fine because I was at work, so it didn't matter.
did they go well?
Oh, it's such a busy day. It's so good though, it's lovely. I've got a great, really supportive team, and I just love working with the girls, and it's an all-female team, which is really interesting. I've never had this before.
Yeah,
Um, but yeah, we get on really well. We've all clicked really well, so it's really nice,
amazing,
really supportive.
amazing.
Yeah.
Good evening, everybody. You're all very welcome to the Ikigai webinar series. We've got Cat Edney with us this evening, and we're just going to let everybody have another minute to come in. We're just going to explain that we're just doing something different with the evaluations and the certificates. We'll explain that in a moment when everyone comes in. So there's a lot happening at the moment around, isn't there? We've got Europerio, the Dentistry Show, the Irish Dental Association. It's everything is on the one weekend, isn't it, this
At the
weekend?
moment, I'm actually really suffering with FOMO because I'm not at Europerio. I don't know about you,
Um,
Siobhan.
and
Oh, it's so
so we
sad.
have quite a few Ikigai educators out there, and they keep sending us all the pictures, making us envious. Yeah, it looks fantastic. I believe the content's amazing.
Yeah, I'm getting lots of updates that it's looking really good, and I keep saying, bring back lots of knowledge. We want to know everything.
Yeah, definitely.
And then
Definitely.
I'm at the dentistry show tomorrow, so I need to get up. I think I've got to get a sort of super early train tomorrow to get up to Birmingham, so that'll be exciting.
That would be good. Yeah, well, let us know how that goes. So you are very welcome, everybody. We're delighted this evening to have Cat Edney. Cat is a dental therapist. She wears many hats, and I just had a peek at her slides before, so she's going to go through that with you, and I'll let her explain that. We are trialing something quite different with the CPD certificates. So at the end of this webinar, Kat will show you a QR code that you go straight through and answer the questions, and your CPD certificate will be sent to you. There'll also be a link in the chat. Now, you can take a picture of the QR code and do it afterwards from your photographs, but we'll also have the link in the chat box. If we try and keep the Q&A section for the questions, so we can keep the chat open for that link to be in there that you can click through on. Any questions, just ask me. And I'm going to hand over to you, Kat. Thanks very much.
Thank you so much, Siobhan. Well, yeah, let me share my slides. Good evening, everybody. We've got quite a lot of you online this evening, despite it being a super busy weekend in the world of dentistry. So that is so lovely to see everybody, and I hope everyone's had a lovely day. I'm really excited to be presenting top tips for ultrasonic tip selection. Some of you may have seen this webinar before, but we always, bring up little tidbits, something a bit different. So yeah, so I hope you get something out of this. As Siobhan has already very kindly introduced me, I'm Cat Edney. I'm a dental therapist, and I'm the founder of the Modern Therapist, which is my training brand, which aims to put therapy back into practice. So this is the empowerment of dental therapists, dental hygienists, and getting dental practices working with us in an effective way. And obviously also as an Ikigai educator, I work with NSK, and I work with JS Davies and a few other companies. So I'm very, very fortunate to do that, and I'm really, really happy to do that. I also work 3 days in private practice in Canary Wharf. And my work is predominantly checkups, dental hygiene, and restorative. And so I have been doing an awful lot. It's been 20 years of treating patients this year. I've been doing an awful lot of using ultrasonic tips. And I'm really hopeful that today I can just take you through some of the uses, the indications, and the techniques for some of the key ultrasonic tips that I love to use. So these are our aims and objectives. Initially, I just want to really make sure that we understand that there are some key shapes and indications of ultrasonic tips. So ultrasonic tips come in all sorts of shapes and sizes, and what I'd love to do is for you to finish this evening being able to look at the tips you've got, recognize what shape they are, and therefore what their great indication would be, what the best indication for that ultrasonic tip might be. Also, we're going to talk a little around piezo technology, how that technology guides our tip technique, and how we're going to be using our ultrasonic because of the technology. We do focus on piezo because that is the technology that I'm using, but I will mention a few other types of ultrasonic cleaning as well, or debridement as well. And then we will be considering how different ultrasonic tips can be used at different treatment stages of patient care. So just making that real definition around what is your patient presenting like, how do they look, and therefore empowering you as the clinician to have the knowledge to be able to make a choice how you're going to treat them. So what tips are you going to use at what time in their treatment stage, and depending on how your patient presents. So I hope that's all clear. Why are we using ultrasonic? Why ultrasonic? Well, you know, ultrasonic instruments have been used in dentistry for over 70 years, since the 50s. They were actually initially developed to cut teeth. So it was an alternative to our traditional rotary cutting instruments. But quite quickly, they did become established as an ultrasonic scaler, which was to remove deposits. And I think this is mainly because at that time, technology just was not refined enough to use ultrasonic technology to cut teeth effectively. And so rotary instruments seem to play out as a better option for that. But dentists were finding that using ultrasonic technology to remove those harder deposits from the tooth enabled the softer deposits around the soft tissues around the tooth and to heal, and to have a not cling on to those softer deposits that we know causes problems for our periodontium. So the mechanical ultrasonic vibration, the mechanical action of the ultrasonic, breaks up calculus, breaks up biofilm and stain in a really easy and effective way. There aren't very many hygienists around now who were not trained on ultrasonics. I know there are a few, but there aren't so many left now who are working who were not trained on ultrasonics. I actually had a really lovely conversation with a 90-year-old hygienist who was selling some hygiene equipment that she had actually bought her for herself. She was selling some NSK Varios 970s, which are standalone ultrasonic equipment, and she was telling me how revolutionary it was to be using high-end precision technology like that. So I just thought that was lovely and really exciting to hear that story. So what are we trying to control with our oral hygiene, with our hygiene prophylaxis treatments? Well, obviously the main thing that we are concerned about is biofilm. And biofilm are these communities of disease-causing bacteria. So bacteria that is virulent. It's not just bacteria that we're used to having that's aerobic and isn't causing us problems, but biofilm is when that bacteria has built up on oral surfaces, created a mass and become anaerobic, and those that biofilm sticks to gum lines, teeth, restorations, prosthesis. It could be on your, you know, Invisalign attachments, all of these things. And we know that about 70% of biofilm is made of live organisms in comparison to calculus, which has got far less viable species. So calculus doesn't have the same level of virulence. Calculus, though, is obviously a big issue as well, and is something that we do want to tackle in oral hygiene prophylaxis treatments. So lovely picture of some calculus for you there. It is essentially calcified dental plaque, mainly calcium phosphate salt, and it builds up again on oral surfaces, including teeth, gums, restorations, and prosthesis. It is covered in and includes viable organisms. So we know that calculus itself isn't live. It's mainly 99% calcified and therefore non-virulent. But because it's covered in biofilm and viable organisms which are live, and because we know calculus isn't one solid mass, it has little pockets in there, it may serve as a reservoir for biofilm that can cause problems for gum health and for teeth and tissues. So calculus is a big issue. And I know if you're a hygienist watching this, you want to see the after of that shot. So there it is for you in all its glory. Because don't we just love removing calculus as well in a really effective way? And this is what patients really come to see us and really love to see the difference when we manage to do this for them in a non-invasive and really gentle, kind way for them as well. Also really highlights that crossbite, doesn't it, when you remove the calculus? So why do we use ultrasonic technology? Well, there's multiple benefits to ultrasonic technology, but one of the main thing is we get this cavitational effect. So cavitation occurs at the free end of the tip of our ultrasonic, and it increases with power. And essentially the area and width of the cavitation cloud varies depending on what tip you use. But it is this imploding that you can see on this video. It's the imploding of oxygen bubbles, which show us that those bubble clouds can displace biofilm and really disrupt that biofilm and stop those masses from being able to affect our gingival tissues. In addition to the cavitation, obviously, we've got the water for heat reduction, and we've got a lavage effect from that water, and also water aids acoustic streaming, which helps to disrupt biofilm as well. So we've got a few actions. We've got mechanical action of it actually breaking up the biofilm. We've got the cavitational effect of those bubbles imploding. I love this scanning electron microscopy images. And then we've also got acoustic streaming and lavage. So all wrapped up in one fantastic tool, which helps us to help manage our patients' oral conditions. So how does that work? Well, you see those cavitational effects happening at the nodes of the ultrasonic wave. So every tip will have this kind of shaped ultrasonic wave going through it. And as the tip vibrates back and forth or up and down at the node, which is the very farthest point of that vibration, you get cavitational effect. At the antinode, which is the lowest amount of vibration, that's when you don't get it. So realistically, what this means is your tip is only effective between that node and the antinode, that very last part of your scalar tip. And it's usually about the last 1 to 2 millimeters, which are super, super effective for removing biofilm, for the acoustic streaming, and for breaking up all the calculus and everything that we've spoken about. So really important that, especially with piezo technology, we bear in mind that that end of the tip is your most effective end. So what kind of ultrasonic technology is there out there? Well, essentially, we can break the main types of ultrasonic scaling technology up into two. You're either looking at piezo technology, or you're looking at cavitron, magnetostrictive technology. Okay, so you'll either have a piezo or a cavitron, and those are our sort of average words for it. There are also air scalers. So it may be that some practices use air scalers, and certainly on the continent, we know that hygienists often use air scalers as well. So I've put that as a little small aside, just in case that's helpful for anyone who's using an air scaler. But piezoelectric power, those scalers operate at quite a high optimal frequency between 29 to 50 kilohertz. These strokes occur in a linear pattern. So that means that if you look at the picture with the blue arrow there, this is our piezoelectric, and it's just stroking, the tip is just stroking up and down linear. Okay, it's just in one direction. And actually the way that that happens is that in the handpiece, you've got crystals, which are a stack of crystals, and they are actually activated within the handpiece, and they vibrate together, and that creates this linear pattern. Because it's just a stack of crystals, it doesn't heat up as much as magnetostrictive, and so you require slightly less water to control the heat on a piezo handpiece, but also it means that you've got slightly wider and more ergonomic handle, just because of that design. And then also it means that the entire handpiece doesn't vibrate. You don't feel vibrations on that. In contrast to magnetostrictive, where those power scalers have a slightly lower optimal frequency, although you do get some available that are up to 42 kilohertz. In magnetostrictive scalers, your energy is converted to vibrations from elliptical stroke patterns. So the unit has these metal rods or stacks. You may have seen them if you've got them or if you've trained on them, and they're just stacks of metal sheets, and your electrical field is pushed through those stacks, they vibrate, and that creates a elliptical power movement of the end of the tip. It just means that every part of the tip on a magnetostrictive tip is active because it moves in this elliptical fashion. It looks like a circle on this picture, but it's actually more like an elongated ellipse. And so it's quite a bit longer than a circle, but it does mean that all sides are active. And then an air scaler, it's actually, they're sat on a dental unit, so they're typically connected to sort of like the fast handpiece, could even be a slow handpiece turbine, and it's actually air driven. So that's why they're called an air scaler. It doesn't mean that you use it with no water. You still use it with water, but it has a much lower vibration. And some hygienists, some periodontists as well, and a couple of really well-known ones actually really quite like to use an air scaler for some applications. So they're not completely obsolete, but you may not have used one yourself. But really interesting to know a little bit more about them. Personally, I use an air scaler for restorative work because you can get slightly lower vibrations with an air scaler, so you have slightly more control, and I use a diamond tipped ultrasonic in that, and it will help me cut tooth, which is that traditional reason that we had ultrasonic in the first place. But today we're going to be, as I say, mainly speaking about piezoelectric ultrasonic scalers, because this is obviously the types that I use, and this is me just showing off my various Lux handpiece and a scaler on there. And what's really key about this is that we remember that just the lateral sides are active. So this isn't going to be active on all sides. So it really is important, if you're using piezo technology, that you understand how to adapt the tip to the tooth to make sure that you're using the best part of that. You get multiple different shaped tips for these scalar handpieces. And obviously, as I mentioned, we get restorative tips as well. And then with NSK handpieces, they relate to, or with the tips, they relate to different settings on your chair, depending on the power setting that each tip needs. So we will talk today a little bit about power settings as well. So here is a little video to explain the action. So again, it's all about that vibrational ultrasonic wave that goes down the tip. And I actually like to explain this to my patients as well, because they quite often, you know, those patients that come in and say, oh no, I don't like that squeaky thing on my tooth. I don't like that water scaler, it hurts. And I explain, you know, there's a wave. And what happens with that is that if I use the side of the tip on your tooth, it will kind of just sweep the tooth, and it will break up the tartar, and it won't hurt, and you won't hear anything. Really crucial is that if you hear the squeaking noise, it will be likely that you're using the back or the incorrect side of the tip, and that will be hitting the tooth, and that will be causing the squeaking noise, the high-pitched noise, and also its sensitivity. So ideally you want to be adapting your tips to the tooth so that just the lateral side, and by that I mean the edge of the tip, is touching the enamel or the root surface. So great, Kat. That's great, but what tip do we choose when? Well, there's lots of different structures we need to consider in the oral environment, and they've all got different shape, different morphology, and also access challenges. So your tip needs to be designed for the situation. So you need to be able to access areas on root surfaces or interfurcations around crowns, distal to eighths and things like that. But at the same time, be really comfortable for you as the clinician, and be effective for the patient. So we already mentioned that we have different settings, your general, your perio, or your restorative or endo settings on the chair. But what does this really mean when it comes to the tips we're choosing? Well, actually, your settings are only relating to power. And so each tip will have their own power recommendation. But more detailed than that, we have got different shape tips. And what we mean by the shapes is if you were to cut the tip straight through and looked down the end of it, what cross section would you be seeing? So this is the typical cross sections you might find within NSK tips: rounded, semicircular, rectangular, a diamond tip, or a rhombus. Okay, and each one of these will have a different indication depending on what you're using them for. I like to make a couple of choices myself, depending on the situation with the patient. And for instance, for my stage 1 patients, I like to use a semicircular cross sections tip because this is giving me 2 cutting edges on the lateral side. So we've actually got a straight edge on the lateral side, but it's curved around the back, so it's really atraumatic. So those patients in stage 1 who might have some inflammation, those tips are much less traumatic. We don't cause any gingival trauma, and so we get less bleeding and stuff like that with those tips. So I'll walk you through how I use each one of these tips and those shapes for each indication. Lovely pictures for you today. So stage 1 is when your patient is first coming to you, and it might be that they've got periodontal disease, or it might be just that they've got heavy calculus buildup, but maybe they don't have any pocketing, but they just need supragingival PMPR, or professional mechanical plaque removal. And typically stage 1 patients, if they've got heavy calculus or they've got heavy staining, you are going to be reaching for a slightly heavier duty type tip. So as I mentioned, it would be a general setting because general is a slightly higher power settings. And it would be, for me, something that's quite good at removing heavy calculus. So it needs to have almost this cutting edge, this straight edge on it. I can hook under calculus, but again, that rounded back to reduce gingival trauma. So this is a close-up look at the G8 tip, and it's called a G because it's a general. So it can be used on general power settings. That's sort of like your slightly higher. It's quite a thick, heavy-duty tip. You see how wide and robust that is? So when it's wide and robust, typically you'll know that you can use a wider tip on slightly higher power settings. This tip, the G8, is amazing for heavy, tenacious calculus. So like the patient you just saw, where you're like thinking, that has been there for 20 years and I'm supposed to get it off in the next 20 minutes. This is a great tip for you. 2 working edges, so you'll see it's rounded at the back there, but then it's flat on the inside, which provides you with these 2 slightly firmer cutting working edges, and it's those edges that you're adapting to the tooth. Little video of that working. Now, I know there's no calculus to look at on a plastic model. It's really sad, but I wanted to show you the adaptation and the fact that we're using that cutting edge to just really clean into the gingival margins and all of the calculus that you will find in these lingual areas. So you'll see that I'm just using that lateral edge, and I like to use a back and forth stroke pattern so that I'm not missing anywhere, and we're just removing all those hard, heavy deposits. That video goes on forever. A really similar tip to G8, but it's a little bit more refined, is G5. So it's a similar length tip to G8 and a similar shape, but it's just a bit thinner. And this is amazing if you've got patients who've got slightly less calculus, but you're needing to get into those interproximal areas. I really love this because it's quite gentle. So your G5 tip is a little bit of a lower setting on the power. It's still general, but it works on slightly lower power settings. And it's really lovely for that sort of 4 to 4 area. So if you've got a pretty well-maintained patient, they've come in with that just a little bit of 4 to 4 calculus, then this is going to be great. It's also excellent for removing staining because it's narrow enough that it can get to those difficult interproximal areas, but it's robust enough to still remove calculus. So I love this. I would say mild interproximal calculus. It's quite a nimble tip. It's quite easy to use quite quickly. So I love this one for like general deposits, but bear in mind, it's not going to remove heavy, heavy deposits. A little bit of calculus for you to look on this model, you see. And you'll see that again, really it's 4 to 4, and I'm using this in a sweeping motion. We obviously would have just a touch of water to keep that cool and for that lavage effect. And again, using those lateral sides. So a nice back and forth sweeping motion, and you're just gross deposit removal with this type of tip. And then still in stage 1, a longer and finer tip, if you have got some interproximal areas you need to get to, would be G6. I also at this point want to mention G16, which is very similar to G6, but a little bit more powerful. So if you're thinking interproximal subgingival calculus, you know, those spurs that you want to get off in that first stage just to facilitate interproximal cleaning, then G16 over a G6. But I do love G6, and I keep these for general patients who come in and are likely to have just a little bit more deposit. You'll notice it's quite a lot longer and finer in the tip, but it's still got that same cross-section of that semicircular cross-section. And it's really great because being longer and more refined, you can get interproximal with molars. And this is, like I say, fantastic. I love using this tip to get around the back of 8s as well. So if you've got wisdom teeth that are slightly submerged or slightly partially erupted, and you know, you always get those little food deposits or a little bit of calculus on the crown there. This is great for reaching into those areas. So it's just that bit longer. You can get further back. You can get interproximally on molars, any little calculus spurs. This is a wonderful tip. So I would typically go around with a more robust tip first to get rid of all of the heavy calculus, and then I'd swap onto G6 just to get those little extra bits from interproximally and around those 8s. So really love this one. Like I say, it is just that little bit more gentle than a G16. So if your patients come with very tenacious calculus, then I'd probably go for a G16 over a G6, but really nice to be able to show you that. And I will show you a bit more of the G16 later. So again, a longer, finer tip. So you can see in relation to the teeth now, there's a lot more tip. But I'm still just using those last 1 to 2 millimeters of the edge of the lateral side of that tip just to do that work. So again, a back and forth motion. I don't like to remove the tip from the tooth because you're constantly having to readapt. So I like to keep contact with the teeth at all times when I'm scaling, and that just reduces the time I'm spending adapting. But yes, this is great for going a slightly deeper into proximally as well, and just getting a bit further back. So really fantastic tip for lingual on molars and stuff like that. So that's great for stage 1. Stage 1, we're obviously removing calculus from the clinical crown, and we're removing tartar that maybe is interproximal and in the way of great oral hygiene. But then once you've got your patient inflammation down, they're demonstrating that they've reduced their plaque scores. Maybe they look a bit like this one who've been trying really hard to make it better, so they're using Corsadil as well. Once we're past our stage 1, we're on to stage 2, and stage 2 is our subgingival PMPR. So this is where we're really thinking about trying to remove deposits from root surfaces and biofilm removal from within the pockets. And now morphology becomes just that little bit more complicated, doesn't it? Because once we're into a pocket, root morphology is something that's very complex. We have concavities, and then we often have furcation involvement that we need to get in, different furcation involvement in different areas, and depending on the complexity of the case. And then, you know, you might have unusual root morphology as well if a patient has had instrumentation in the past. I want to go back to the tips that I'm going to speak about, because I want you to just get a bit of an overview of why. The G16 is the one we were talking about slightly earlier. It's a little bit like G6, so you'll see that now. But the difference is it doesn't have that semicircular cross section. It's got more of this oval cross section, which just makes it just that little bit flatter. So really great for access in terms of getting a tip that goes right into a pocket with minimal trauma, but has a working edge. Your G16 is an amazing all-rounder. And typically when I'm asking hygienists what their favorite tip is, especially people who work in industry with NSK or with other companies, this is the type of tip that people always go back to time and time again. And then in terms of treating difficult areas, so we're talking burnished calculus or interfurcations, I really want to showcase today diamond coated tips. Now, these are not for the faint-hearted, and I don't recommend them always, but certainly if you've got burnished calculus or really tenacious spurs that are, or spicules that are on root surfaces or infurcations, then we'll be talking about those tips as well. So this is our G16, and it's a really long and fine tip. Like I said, it's got this sort of squished oval cross section, and being a general tip, you can still use this on really high power settings. But for me, for perio, I still like to keep it quite low. It is quite an effective tip. I tend to have this on a G1 or 2. The most I'd go probably is a 4 or a 5. But helpfully, all the tips come with their power settings on the packet anyway, so you never need to guess. But for me, I like to have it quite low. Again, this is excellent for reaching the posterior subgingivally and interproximally. And with those two working edges, you're spending a lot less time trying to adapt into different areas because you've got two places you can use it. Here is my G16 working on the lingual of this lower premolar, on this lower right 4 and 5 area. And you can see again, I'm adapting that working edge and just using the last 1 to 2 millimeters of the tip to do all that handiwork for me. So probably my favorite tip. And then within stage 2, as I said, P1D, the D means there is diamonds on the end, and aren't diamonds just a girl's best friend? So what's great about a diamond tip is that you are able to remove that burnished calculus, those heavy spurs, those little tricky black spots that we struggle to get rid of. This will be getting that for you. And I want you to just notice that the P1D is actually slightly curette shaped. So you will use it in a sort of curetting motion, and you're using that last tip lifting up and down. And then really interestingly, those diamonds do wear off of these tips. So when you're using a diamond tip, it can wear off. But once it's worn off, it would be considered a P1 tip, which is exactly the same shape and works like a normal perio tip that doesn't have the diamonds. So this is this tip in action. And you can see I've just snuck it into the pocket there, and it is using the lateral sides like a curette though, in a curette motion, and just following that root morphology around. So I'm trying to ensure I'm staying in contact with the root at all times. You can see I've managed to get right into the furcation with that, and being a circular cross section, furcations are often rounded as well, and so having a circular cross section on this kind of subgingival tip can be really helpful for those furcation areas. And then a lot of people, I think, get really confused by these twisted tips. But the P2D and the P3D are very similar to the P1D. It's exactly the same concept. It's like a curette, but you'll see it's got this twist to it. And so one is for left, one is basically considered a left-handed, and one is considered right-handed. And that means that the one tip will clean the buccal surfaces of the upper left, and then the lingual surfaces of the lower right. Okay, so opposite sides, and then vice versa for the other tip. And it looks really strange outside of the mouth, but once you get that into the mouth, it suddenly makes sense, and you'll be able to work out how that goes. And what that's doing is giving you a shank that is coming out away from the tip and directed towards you, the clinician, and just giving you that little bit more comfort when it comes to trying to adapt this tip into really awkward places. So you'll see how I've managed to now adapt that tip into the furcation. I turned the water off and stuff for this one just to get you to really be able to see how that adapts. So it's allowing me with that shank to sit into the tooth in a little bit more comfortable way, and it's better for the operator, for the clinician. Pardon me, I sneezed. I'm super allergic to my cats, and she's sat on my lap right now, so apologies about that. So yeah, P23, P3D, they're circular cross sections with those diamonds around them. Okay, so we have removed the supragingival heavy deposits. We've seen a massive plaque reduction and inflammation reduction with our patient, and we've allowed them to move to stage 2. We've instrumented gingivially, we've removed those hard calculus deposits, and now our patient is back. They need maintenance. What are we going to do? Well, I really love to use rounded cross-section tips on low settings just to remove biofilm. Now, this I laugh at the pictures I put up because this is your typical patient that comes back, you've had all that perio treatment, they come back with a ton of turkey teeth or bonding or whatever it is they do to let you down. But we move, we do what we can do with them. So one of my favorite tips for maintenance is the P20. And the P20 tip is, it always has a little place in my heart because for the first, I don't know, 7 years of working as a hygienist, this was the only tip I had. And I had no idea that I was, there was anything else out there. The P20 is a really long, fine, circular cross-sectioned tip. It is not designed for heavy calculus removal. It's not really designed for calculus removal at all. It's more about biofilm disruption, and it will remove moderate calculus and soft early calculus. But yes, this is the tip that I chose from the get-go because it was long, it was thin, I could get it into loads of places. And guess what? Patients didn't complain about discomfort or pain because it was a P-tip and it was just vibrating really gently. And so I loved it. Now I know better, and my life is a lot easier with a multiple option of tips to use. But the P20 always has a special place in my heart, and it is one that I will reach for I would say 90% of my maintenance patients. So when they're coming back for just a little bit of stain or biofilm removal, this is the tip for them. You can actually use it on quite high perio settings as well. And what's great about these long shanked tips is you can reach into really far reaching places. So again, right into pockets, right into unresponding sites. I found this is really helpful around the back of upper eights or into furcation areas because of that round cross section. It's really good for furcations as well. So I really love this one. And then the P25 right and left are basically, again, P20, but with a right and left curve. And so if you are seeing patients who have limited opening, have got interesting root morphology, recession interproximally on molars, large crowns placed that have got, difficult prostheses around them, even getting around bridges. These are fantastic tips for that. You will want both. You want both P25 right and P25 left on your tray for treating one mouth, because as I say, one is for the upper buccal, lower lingual, the other is for the other side, upper buccal, lower lingual. So we will find that they sort of like work together, and you will be switching tips using these, but think of it as a P20 for awkward places. And once you get in there with these tips, you wonder how you ever survived without them. They are just fantastic to use, and they do adapt really well and really reduces operator stress and strain. I find that when I'm using curved tips like this, I'm not leaning into my patient's mouth anymore. I'm able to sit up straight and hold my arm in a neutral position so that I'm not getting any sort of RSI strain in my wrists at all. So definitely recommend giving these a whirl if you get the opportunity to order these left and right bent tips. These are really helpful to use. And then just a little video so you can see that one in action, because like I say, until you get it in the mouth, it's really hard to understand exactly how that will work, but I hope you can recognize that it's similar to a shank that we'd find on a curette. And so once you get it in to the mouth, you can really tell where that's going to work and how that's going to work for you. Again, adapting that lateral edge. So you see I moved straight out of the pocket there and back in again on the other side, the other lateral edge of that scaler, in order to really adapt to the root surface of this tooth. So care and maintenance. So we've got our patients all sorted. How are we looking after these tips now? How are we going to care for them? Make sure that they stay unbent and nobody touches them. Well, the first thing is with the handpiece and the lead. As soon as you've finished, you want to be cleaning these with alcohol-free wipe. Clean the handle, clean the lead, and then pull the handle off with the NSK Varios handle. You don't twist it, it's just a clip in and out. So you just pull that off and you would put that into the sterilization cassette. So you've got one handpiece per patient use that gets obviously sterilized after every patient, but they come with a sterilization cassette, which I really recommend using because it's got space in there for 4 tips. So there's plenty for the tray or the treatment that you've been performing for your patient, plus the handpiece, and it just keeps those handpieces really safe and away from the metal tray that we often sterilize on. And so you don't get that thermocycling issue that a lot of handpieces get, where if you've put them on a metal tray, they get super hot and then you take them out and they get super cold really quickly and can crack. So ideally, the first stage is give it a really good wipe. The second stage is pop it into your cassette for sterilization. And then the other thing is maintenance. So think of it just like you looked after your patient. We need to also have maintenance phases for our tips. And we need to be aware of tip wear and when to replace our tips. Obviously, that if you're using them correctly, you'll find that they wear a lot less. If you use them on the correct power settings, you'll find they wear a lot less, but they do need to be replaced on a regular basis. So here is just our little recap. You'll find that most of your ultrasonic tips do come with a torque key like this one. And the torque key is for you to safely place your tip on and remove your tip from your ultrasonic handpiece. Those torque keys, you want to make sure that you just click them once, because they have a self-limiter in there that stops you from over-tightening. So that will just keep things a lot safer and a lot less likely to be broken if you're not over-tightening them. As I said, you always just pull to open. There's no unscrewing with these handpieces. So the 2 little dots just connect. And then these are going to go into a cassette like this one. So this is our sterilization cassette. And as I say, there's plenty of space in there for your tips. And the whole thing goes into the autoclave. So you just place it in there and the whole thing can be placed into a normal cycle on your autoclave. And obviously you're sterilizing between every patient. And then if you don't have one already, NSK do these brilliant tip wear cards. And you would just offer your tip up to the space that's on those cards and see whether or not your tip needs replacing. So you find the right tip for the space for the one that you're looking at. And these have got different colors depending on how worn out. So if it's green, it's okay. If it's yellow, in the yellow zone, it might have dropped by a quarter of efficacy. And if it's in the red zone, you've lost 50% of the power that tip can give you. And it's time to throw it out and get rid and get a new one. If you don't have one of these tip wear guides, please contact myself or Siobhan or anyone at NSK, because we can get them sent to you, and they're a really helpful way of explaining, especially to your principals, that it's time for a new set of ultrasonic tips. So please do let me know if you need anything like that. And then actually we have tons of information on these tips with the tip and power guide. So anytime you go to the NSK shop, or if you need to, if you want to purchase any ultrasonic tips, also have a look at the tip guide and the power guide, because every time you get a tip, you want to understand how you're using it. You want to make sure that you're using them on the right power settings, and that you understand the indications for the tips, and all that information is in this really handy guide. So I'm constantly referring back to this if I've got something new turn up on my doorstep. Now listen, NSK have a huge range of tips, and I've just gone through maybe a few of my favorites today, but there might be a couple that you've got in your drawer that you're not sure about. So I'm more than happy for you to contact me. I'm sure Siobhan feels the same way. If there's anything that you can find in your drawer that you wonder, you know, actually I've never used this one, or is this one worn out, or is it bent, please do send me a picture, and I will be able to let you know if it's, you know, if it's something that I recognize, and how you can use that as well. And then last little thing is, you do get a 40% discount at the NSK shop today. So this discount code is valid until the end of May, and that's WCE 0525. And there is a QR code here for your evaluation. So as Siobhan said, take a screenshot and get that QR code, and we will also put the evaluation URL in the chat. I think Siobhan has already done that. And you'll be able to then use that evaluation to get all your answers done. Oh, I think I stopped sharing for some reason there. Hang on a second. Let me see if I can get it back.
You're still on my screen, Kat.
Oh, there we go. It just disappeared off of mine.
Okay.
Well, that's me for tips, but I just wonder if anybody has any questions.
We do, yeah.
Then I'd be happy to answer them.
Some people just might have come in a little bit later. So just to explain again, that QR code is for your evaluations. So answer the questions now, and you can take a photograph and do it after the webinar this evening. Or if you have a look in the chat, there's a link to the evaluation that you can do now. So you can just take your time doing that while we're just going to ask some questions. And the first one, Kat, is how do we scale full arch acrylic implants?
Oh my word. Well, personally, I will always, because you know, you don't really get an awful lot of calculus and debris building up on acrylic. So you do sometimes, but not a lot, and it doesn't tend to stick really, really hard like it does to natural tooth structure. So I would normally go for perio tips. So that P20 is a really nice option. And if you absolutely do have to scale, if you're using Piezo, I really love the P20 on a slightly low setting, and I'll use that, like I say, adapt that round to the, oh, don't worry everyone, I'm putting the link in the chat. I think Siobhan, it might have gone to just asked. I've added it.
Really? Just let me have a look at that.
So yeah, so you can use a P20 or a round cross-section tip on really, really low power settings, and that shouldn't cause any problem to the acrylic, and you should find that you can still lift debris in that way. However, if it's just biofilm and just stain, I would probably more than likely try and use powder therapy for those prosthesis, just because it can be slightly more effective and quicker. But yes, if you're limited to Piezo technology, then I would go for a round cross-section ultrasonic tip on lower power settings.
So if it's healthy, they say no ultrasonics, better to go for the air polishing like you're saying. If there's calculus on the prosthesis, a peak tip only, because the stainless steel could potentially scratch the acrylics. So we need to be careful. And the only time we could really consider the stainless steel is when there's a pocket peri-implantitis. it's quite a large topic, really, just to answer very quickly there.
And also, I would say that there are mixed reviews on Peak, aren't there, as well, Siobhan? So I think it's one of those things that you have to be a little bit in touch with your dentist, that's, if you can, that's placed this prosthesis, and see what they want you to be doing as well. It is tricky. Catherine speaks a lot about prosthesis as well, doesn't she?
Yeah, so I was just liaising with her there just to make sure, because she's quoting the S3 guidelines and things. So yeah, if you want to send us an email to if you want to know anything further about that, it's just anonymous, so I don't know who it is. And how to remove stubborn stains, Cat.
Yeah, I mean, again, it's all very much about adapting that tip correctly onto your tooth surface. And what you'll find is that if it's a really heavy stain, I mean, I'm talking beetle nut staining, for instance, then you probably want to go for those sort of robust G8, G4 kind of tips that have got those cutting edges. I don't particularly like to go for a round cross-section tip for that. You really want to have something with a bit of a cutting edge, but I certainly wouldn't reach for the diamond edged ultrasonics for those, because it can be slightly more invasive than you need for that. So yeah, certainly I would be going for like a G8, a G4, something nice and robust with a cutting edge that you can just sweep that stain off. And if you keep in contact with the tooth, you can adapt correctly to the tooth, and actually that will reduce the amount of effort you're having to put in as well, without having to constantly readapt.
What would a P10 be used for?
Oh, do you know, the last time I looked through the tip catalogue, I did pick out a P9 and a P11, but I haven't personally used a P10. So Samantha, send me a picture. And what we do is we always just look at the shape and the cross section, and then you'll be able to look at the indication. But for instance, a G11 has got a rhombus shape edge cross section, so it's a little bit more aggressive. So I imagine that a P10 might be similar.
Okay. And how do sensitivity experienced by patients all of the time?
Oh, it's so difficult, isn't it? If what I would say is, if every patient is sensitive, then it might be that your technique needs slight work. So if it's every patient that's sensitive, it might be that you're not working on adapting the tip to the root surface or the tooth surface enough. Or it could be that we are a little bit too high on our power settings. It might be that we're using a tip that's too aggressive as well. So these are the things I would try and reduce, or try and work on. If you're really struggling with technique, what we often do when we're training is get a quail's egg, and we adapt the clinician who's learning with us to stop them from making that squeaking noise. So if you don't hear the squeak, you're less likely to get sensitivity. So you might want to just get some way of practicing like a quail's egg, and just practice your adaptation, lower your power settings, start as low as possible, and then work up if you want to, just slightly until you're removing the stain from the egg. And then you can start doing that on patients as well, and you may start to see a difference. But yeah, absolutely, we're going to be looking at lower power settings, less aggressive tips, so rounded edge tips, working on your technique, and obviously it's about pressure sometimes as well, so just being a little bit gentle. But I know it's really hard, that you do have those patients. I don't know if you're the same, Siobhan, but it's those ones that are always the same, coming back saying, no, it's really sensitive. And I think sometimes it's just a case of, working with the patient, and remembering that ultrasonicking isn't the be all and end all. You don't have to do it for every patient.
There's a lot of people on this evening. So there's a couple of people saying that they can't get through on the link, but it could just be that everybody's hitting it at once. Just give it a minute. Is there many? Could you give me a few yeses that people have filled it in, if you don't mind, please? What is can the discount code be used for buying the various Combi Pro, or only the tips?
I believe it's on everything in the shop. Am I right, Siobhan?
Whatever's on the shop, yeah. So go and have a look.
Yeah, go have a look.
Yeah. And what is the best tip for thick calculus on lower anteriors, and which tip is your general workhorse?
Yeah, so if it's really thick calculus on lower anteriors, that's when I'm getting out my G8. You know, that sort of like you're holding the teeth in and getting rid of the cement that's keeping them there. That would be a G8. But my general workhorse would be that G16. It's wonderful, and it's one of the ones that, you know, if I'm going into a practice and they're asking me what should we buy, I tend to go G16 to start with, because it's a good all-rounder. Supragingival, subgingival, high settings, low settings, it works really well. But if you do have patients that have got tons of, you know, wall-to-wall, 4-to-4 calculus, then you probably want to start off with slightly more robust tip, because you just otherwise get lots of tip wear and you'll end up replacing them a little sooner than perhaps you want to.
Which tip is the best for molars with furcation areas?
So two types really. I really like these left and right hand bend tips. And then you've got the two that I showed this evening, which is P2 and 3D, and then the P25 left and right. But there is also P26 left and right, and that has a slightly more cutting edge. And so if you're not getting if you're just getting calculus out of the root surfaces of furcation areas and not right into the top of the furcation, then having a cutting edge can be a little bit more helpful. But if you're trying to get into that real top part, that real curved part of a furcation, then you really want a rounded tip. So either the diamond coated P2 3D or the P25 left and right as well.
Okay. It is super busy. Everybody's really trying. I think the system is a little bit under pressure. We are trialing this, as we said earlier. We will go back to our old way if it doesn't work, but it did work. It was very successful last week. So let's see how this evening goes, but do bear with it. If you can always email us, nskikigai@gmail, and we can send you the link that way as well. Can we use ultrasonic tips for patients having pacemakers?
Oh, this is the age-old question, isn't it? It's an age-old question, and typically what they say is that the newer pacemakers are shielded and they are fine, but you would want to get confirmation from the patient's physician just that they are happy for you to use it. Listen, most modern pacemakers these days are completely non-issue, but you know, ultimately, if it was your family member and you were unsure, you would find out before you tried. And so I would recommend doing the same. Really find out from the patient's physician.
What about for the interproximal calculus on molars that you see on bite wings?
Oh yeah, I mean, I love those little spurs of calculus. I'm sure you do too. And yeah, certainly that nice long thin G16, that's where I'm going with that one. That's great. Or the G6 is pretty good for that as well when you're sort of more premolar area, because it's just that little bit shorter, so it might be a little bit less cumbersome for getting into proximal. But yeah, really love G16 for that. And it's a real, like we said earlier, a real workhorse. And it's got those two cutting edges, so you can sort of hook up one side of one root and then down into the pocket of the other side without really having to readapt too much. So yeah, really lovely one to use.
Gonna love this one, Kat. Are there any good ones to remove old composites or attachments?
Oh yes. We're laughing because I've just had all my attachments taken off and I'm really enjoying my smooth teeth. It's great. Yeah, I mean, listen, every time you work on composite with an ultrasonic tip, what you will find is you're going to blunt your tip, and you're going to wear it a lot quicker. So my real answer is you shouldn't use an ultrasonic for that, but you know, we all do a little bit. And so what you're looking for is, don't think about the exact tip, because I wouldn't necessarily say buy a tip specifically for composite removal, because it's going to be such a shame because you won't have it for long. But what you're looking for is a tip with a cutting edge. So again, G8, G4, those kind of cross sections with that semicircular working edges. is going to be great for hooking and removing those little stubborn bits of bond or attachment glue.
Are there any tips to dry vibrate composite to make it flow into the corners?
I would not recommend this, and the reason I'm not a fan is because it's really hard to control no little tiny bits of moisture or water coming out that are remaining from your ultrasonic tubing, even if you've stuck the water off. I'm not a fan of that technique. I just think you risk contamination. So that's not my kind of where I'm at with my dentistry. But I mean, I do know that some people do it. I personally don't, so I wouldn't be able to give you any tips for it. Also, obviously, we have to be really cautious about overheating teeth, especially when we're near pulp. So just be a little bit cautious about that.
And what do you use to remove interproximal composite overhangs?
I use a fast handpiece and a diamond interproximal burr. You can use an ultrasonic, and Lauren and I on our composite maintenance course have taught with both ultrasonic and fast handpieces and slow handpieces. There's multiple different tips, but me personally, I don't like using an ultrasonic, so I just don't feel like I've got quite the same level of control as I've got with a fast handpiece and a diamond burr. Red banded burr, which is a really thin a diamond grit, and very, very cautiously and carefully you can remove that. And there is nothing to say that you can or can't use whatever equipment you like to use, as long as you're trained and competent to use it.
Fantastic. I think we've come to. Oh, if a patient had a heart condition, what is the safest local anaesthetic for a patient with perio? And can you please share about antibiotics prophylaxis before dental treatment guidelines? That's not necessarily what we're covering this evening, but it's up to you, Kat, really. It's
Well,
half
I'm
past now.
I don't think it's something that we can cover today, because ultimately in terms of antibiotics, that's not our remit, so we would need to be working with a prescribing dentist for that. So you need to be obviously talking to your prescribing dentist about antibiotics, and then it's like there are multiple different anesthetics that you can use. I would really highly recommend doing the exemptions training course, because it does cover all of this. It is a couple of hours. I know it's long, but actually the people that put the exemptions training course together, which is free, by the way, is amazing. So I would, really recommend logging in and doing that if you want to understand a little bit more about local anesthetics.
Okay. Are the diamond tips good for caries removal?
So there's different types of diamond tip. You've got your diamond tip for calculus removal, and then you've got restorative tips, and they are different, and they've got different types of diamond. So restorative tips do not come under the perio or prophylaxis part of the NSK website. They are under restorative, and you've got different shapes depending on different indications again. So you've got crown prep type where there's diamond all the way around that ultrasonic tip, and then you've got interproximal box diamonds, and I love using them. I find them really helpful for removing spurs of enamel after I've prepped teeth. But yeah, highly recommend trying them out, but it's not the same tip. So just make sure you get the ones that have got the right connection, because a lot of them are designed for air scalers, which is why I'm using them, the air scaler.
How can I make my tips last longer?
Lower power settings, fantastic maintenance routine. So making sure that you are using the torque wrenches correctly, the correct torque wrenches that have a limiter on them, that they're not dropped, that your decon support understands how to look after them, and also not pushing so hard. What I love about my Varios Combi Pro 2 is that it gives feedback. So if I push too hard for the type of tip that I'm using, it will automatically lower the power ever so slightly that it's inputting into the handpiece. Although it doesn't change my settings, it just adjusts slightly to make sure that I'm not overdoing it with the tip. So I really recommend considering a feedback mechanism like that, like on the 970s or the VCPs, that really help with stopping us. But ultimately it's how you look after it. So using the correct tip for the correct indication, not pushing too hard, lower power settings as low as you can get away with.
Okay. Do you recommend the larger diameter diamond tips?
I don't know which ones we're talking about here, because all of the perio tips are the same diameter, but potentially you'll talk with, this is anonymous, is the same anonymous that was talking about the restorative tips. And no, I personally think the smaller the diameter the better, because you have more control. Yeah, for restorative it was. So yeah, no, it's I like the smaller ones just because I like to have more control, and I like to be as minimally invasive as I possibly can.
Will the normal Various get an update with heated water? Yes.
Ooh, well, I mean, it's not the same Varios. It's going to be the new Varios too, but yes, it does have heated water. I'm using it at the moment, and patients love it. I love it. So yeah, I'm doing an evaluation on that machine at the moment, and certainly that is going to be available very soon. So keep an eye out for VCP2. It's really slick and really professional, and I think it's a wonderful addition.
Do you prescribe any mouth rinse after PMPR? Because some patients say they felt sore gums and painful after deep clean.
Well, quite often, if I will say, if they are sore, to use hot salt water rinses, but I don't typically have patients come back who are sore, because we work really hard on reducing inflammation before we even consider going into doing subgingival PMPR. So inflammation has reduced so much that patients don't tend to be uncomfortable. And then obviously we're trying with a really minimal approach, and that's the whole point of using the right shape tips and the right indications to get into these areas without distending pockets, without damaging tissues, trying to be really careful of interproximal papillae as well, and not disturbing that, just to aid healing. So ultimately, if you're doing all of these things, then you should find much less discomfort for your patients. Siobhan, are you not speaking about minced this weekend?
I sure am.
So maybe you can come in on this question.
It's about the situation that's in front of you, but it's about having the settings right. It's about having the tips right. A minimum invasive approach, really. I think we'll probably have to do a webinar in the autumn on it, because it'd take a bit of time to really go into explaining the minced protocol.
I think so. But minced is, as an overview, going to help people to be much less invasive when they're instrumenting non-surgically. So hopefully that would also translate to less discomfort for your patients afterwards, and therefore you wouldn't need to be necessarily prescribing any mouthwashes.
Yeah, I think it would be a good idea to do a hands-on training course, really, with the tips and get them into your hands. In fact, we're going to be at the Scottish Dental Show. We're going to be at OHC BSP this year. What else is going on, Kat?
Oh gosh, it's just constant, isn't it? But yeah, I think
And there'll be
OHC
small
will be
courses in
a big one.
Stevenage. NSK has moved offices now, so we have a larger room, and that will be back up in the training centre. So we'll let you know what's going to be out there. Can use ultrasonic tips to clean old composite and build up restorative instruments. And the
Yeah.
build up on.
Yeah, you can. You absolutely can, but you'll ruin the tips.
Would it be possible to send you pictures of 2 NSK tips? I'm not sure about via Instagram.
Yes, absolutely, Agnieszka. You know you can always message me. Please don't feel like you can't. Your messages are always welcome.
Okay. I hope you all managed to do the evaluation. If you didn't, I put the email address into there. Just email me straight away and we'll have a look at that. As I say, we are trialing it. And thank you for some of you that gave the feedback on it. And, we'll see how we proceed forward with that. Kat, thank you very much.
Thank
You
you
can
for
go and get
having
your dinner now. She rushed in
me.
from work. Excellent as always. Thank you very much. And thank you everybody for joining. Next week, we have Sheila Scott here, and she's going to be looking at, she's non-clinical, so she's looking at it as more of a business consultant, looking from the patient's view. Very interesting, looking at about, profit within practice and so on. She's actually retired, but she came back out of retirement to go and do some workshops for Chris Barrow. And we managed to entice her to come and do a webinar before she goes off completely again. So join us next week for that. And you'll come back again, Kat, and we'll do this again sometime.
We will do indeed. I just want to say I've heard Sheila Scott speak a number of times and she is brilliant. So that is an amazing one. Don't miss it next week.
Lovely. Thank you. Okay, thank you for the feedback. Have a wonderful evening, everybody. Thanks again, Kat. Thanks, everybody. And we'll see you same time next week at 7:30.
Take care, everybody.
Take care. Bye-bye. Bye-bye.